In this clinical correlation lecture, we will consider the disease hereditary hemorrhagic telangiectasia. So let's examine a case of HHT. This is a real case report. The link for this case is found at the end of the lecture if you want to read it directly from the literature. A 29-year-old patient with HHT presents with progressive exertional dyspnea. Dyspnea means the patient has difficulty breathing. Progressive exertional dyspnea is marked by an increase in difficulty as exertion increases. So as the patient runs, the longer they run, the harder they run, the more difficult it becomes to breathe. So it rises and falls with the exertion. When you're dealing with something like that, one of the things that you need to rule out is pulmonary arterial hypertension, meaning the patient's blood pressure inside their pulmonary arteries is too high. And they go in and they put in a heart catheter to measure the blood pressure, and they confirm that the pulmonary arteries do in fact have hypertension. Pulmonary hypertension is not something you would really suspect in a 29-year-old patient. That's something you'd expect in an older patient, maybe with some history of underlying heart disease. And so they do a genetic analysis, and they find a missense mutation in the patient's activin receptor-like kinase 1 gene. In this case, the gene is found on chromosome 12 on the Q arm at position 13.13. It's diagnosed with as HHT type 2. They perform a CT and they show a pulmonary arteriovenous malformation, PAVM, with a 5 millimeter diameter feeding artery in the right lower lobe. Here's a picture of the patient's scan, and you can see here in the white arrow right here that the patient has this connection. So if you think about what the words mean, pulmonary arteriovenous malformation, which means there is a connection between the arterial system and the venous system that is not supposed to be there. Now, when you look at a lung, if this is not the sort of thing that you look at frequently, it can be difficult, to really tell what you're looking at. Here, obviously, we have the heart. Here's the apex of the heart. So this is the patient's left lung. This is the patient's right lung. And this connection right here is not supposed to be there. There's not supposed to be a connection between the arterial system and the venous system. Here is another scan. You can see this much more clearly. This is this PAVM, this pulmonary arteriovenal malformation. This is an extremely dangerous structure. The patient's life is in a lot of danger because if this connection ruptures, the patient is at a high risk of bleeding out in their own lungs. And here you can see the structure from the side. So one of the things you could do is you could embolize, block that feeding artery. The problem is that the patient already has increased pulmonary hypertension, and if you go in there and you embolize that feeding artery, you're going to increase the pressure. That's kind of the opposite of what you're trying to achieve here. So instead, what they elect to do is an endothelin-1 receptor antagonist. Now, if you've taken physiology course, you're probably aware that endothelin-1 is a vasoconstrictor. Okay, that's one of the functions of endothelin-1. And so if you use an endothelin-1 antagonist, okay, then endothelin-1 is not able to do its job of vasoconstriction. So in the presence of an endothelin-1 antagonist, you should see vasodilation instead of vasoconstriction. And the drug they use in this case is bosentan. Bosentan is a receptor antagonist against the two receptors. There are two receptors for ET1. It's called endothelin receptor A and endothelin receptor B, and this drug works on both of them. So they give the drug to the patient. Initially, it's successful. For about a year, things seem to be going pretty well. Then the patient comes back because that exertional dyspnea has returned. They give iloprost, which is another drug that causes dilation. It's a prostacyclin analog, in addition to the bosantin, to increase that vasodilation. This works for about 3 months until the patient presents at the local ER. The patient presents with a massive right side hemothorax. Hemothorax means blood in the chest, most frequently in the lungs. The patient dies in the ICU due to the fact that the PAVM ruptured inside their pleural cavity, and the patient unfortunately bled to death on the inside of their lungs. This is the pedigree of the patient in question. Here is the patient right here who has the HHT and the pulmonary arterial hypertension. You can see they are one of 4, and here is their family tree. So HHT, also known as Osler-Rendu-Weber disease, stands for Hereditary Hemorrhagic Telangietctasia. There are 5 subtypes of HHT. The one in our case was type 2. They all behave in an autosomal dominant fashion. The locations affected include mutations in chromosome 5, 7, 9, 10, and 12, depending on the types. These genes, therefore, are potentially HHT3, 4, ENG, GDF2, and the one from our case, ACVRL1. Type 1 has a prevalence of 1 in 5,000 births. The mutation occurs at the location of chromosome 9, Q arm, position 34.11, and it's caused by the endoglin gene, or the ENG gene. So what does endoglin protein do? Endoglin is a membrane-bound glycoprotein. It's found within the human vascular endothelium. It's also found on other cell types like the proerythroblasts and monocytes that are produced in the bone marrow. Endoglin as a subunit is also found as a portion of the immunological signaling compound TGF-beta. So when we're thinking about HHT1, what sort of signs and symptoms do we associate in these patients? The mean age of onset is 12 years. 90% of patients will have presented with symptoms by the time they're 21. And the primary symptom is, sign is telangiectasia, which means spider veins. You think of varicose veins, particularly around the skin of the mucous membranes. So here's a patient with telangiectasias of the lip, and so what we see here is these deep purple, they look like little mini hemorrhages, little acute hemorrhages. This is because of the dilation of the veins, and that's what's causing the blood to pool there, which is leading to that deep purple color. HHT type 1 patients present with a number of vascular problems. They are telangiectasias of the mucous membranes, the lip, the tongue, the palate, the conjunctiva around the eyes, as well as inside the nasal cavity. So one of the things that you'll see is a lot of nosebleeds in these patients. But more seriously, what you're worried about are GI hemorrhages. GI hemorrhage is extremely difficult to deal with. Or the pulmonary arteriovenous malformations like we saw in our case. And this leads to a high degree of morbidity and mortality in these patients. Okay, so there's the brief introduction to HHT, an autosomal dominant disease that follows a Mendelian pattern, leading to malformations of the venous system. Here is the link for this patient's case. If you want to read it, it's not required for you to do so. But if you'd like more information, you can follow this case.